countries. We've done, there's a recording in progress. I've been informed, thank you, got it. In these 19 case studies, 234 key informant interviews have been conducted. That's a lot of interviews, that's lots of information from a variety of partners that we've tried to make sure reflected a good sample from all the different constituents. And also 250 people or more have been involved in validation workshops at the country level. So this is over 500 different people, oh, well, not always different, but that's a lot of people, participation from countries, from partners. So we're extremely grateful and hope that we can really use this to accelerate pandemic response in general, as well as others. So on that note, I will hand over to Heiko, who will be taking us through over the next few months, presenting findings, but also, as said, the deep dives into other areas. So I hand over to you, Heiko. You may already know him from other hats he's worn previously, UNHCR. But we're very grateful to have him here. And over to you, Heiko.
Thank you very much, Eba, and welcome everybody. Quick introduction on my part. My name is Heiko Hering. I've joined the Global Health Cluster recently, specifically for taking this task of looking at some of the lessons learned and good practices that came out of the COVID response in humanitarian settings. And in that regard, we're looking specifically at the 3 studies that Eba already mentioned. Today, we're going to look at the coordination study, and I will shortly introduce our speakers for the day. But before I do so, again, just some housekeeping rules for today's webinars. Eba has already said that there's interpretation available. On the bottom, you can find the interpretation button. We have English, Spanish, and Arabic. Well, English, yes. Arabic, French, and Spanish. We also have, as you can see, started recording this session. We would like to make this available then for people to revisit, or those who were unable to join us today to see the session. We will make this today very interactive. We want to hear from you. So I will just join my screen to present you with the agenda of today. We have decided to cut the findings because there's a wealth and a lot of findings that these studies picked up, and the coordination study in particular. We have decided to cut them in 2, and at the end of the session 1, which is looking at government and humanitarian coordination, we'll be having a case study from our colleague Laura Osorio, who will join us on the panel, who will be presenting her experience from reaching populations affected by crisis in Colombia. We will then open the floor to discussions, and this session is open, so anybody can unmute themselves and intervene. But however, we would like to ask that you post your question in the chat so that we can moderate it better. And then if you want to intervene, please raise your hand first so that we can manage this in some way. In your interventions, we would like you to focus on the questions that we are posing here. I will come to these in the sessions again. So in the first section, we want to ask you, how did it work for you? How did coordination work for you? Then we will have a follow-up session that looks a bit more on the strategic part of coordination and a technical coherence. And we want to know from you, how did your work benefit from it? We will then look at challenges, at some of the good practices that the study has collected and the key takeaways. And we're asking you, are we on track for learning for future pandemics? Because this is going to be the starting point of what Eva already said, of a series of events, of tools that will enable us go into the future with better preparedness. Basically, focus on the practical learning of the COVID response. We'll then look at some of the recommendations and go over the next steps before we close with questions and answers. Now, we also have made a word cloud vote, which I'm shortly going to copy the link in a chat. We want you to head over to the to the link, and just give us 1 or 2 words on your experience of the health cluster coordination during the COVID-19 pandemic. Express how you felt about it. Yeah, so I'm copying this into the chat right now, and then we can ask you to head over and while you're listening, following the presentations, just to input 1 or 2 words that come to your mind. Don't overthink it, just throw it in. So before we go on, I would like to introduce our speakers for today from the operations partnership, the partners that conducted the study. I am honored to be on the panel with Kim Creech and Helen Leinecker, and also on the panel supporting us during the discussion will be Eva, and as I already said, Laura Osorio will join us for presenting the case study from Colombia. Kim, over to you.
Thank you, Heiko. Actually, it's Helen who will start today.
Oh, okay.
Okay.
Go ahead.
Hello, everyone. I'm going to start by just presenting briefly the purpose, objectives, and scope of the study. So as Heiko said, the study was conducted independently by the Operations Partnership with guidance from a steering group under the Global Health Cluster COVID-19 Task Team. The steering group included the Harvard Humanitarian Initiative, ICFA, IOM, the WEDI Initiative, and WHO. So the purpose of the study was to review how coordination in humanitarian settings has been adapted to the COVID-19 pandemic, including maintaining essential health services. And what we aimed to look at was to identify good practices, successful strategies, and challenges in the adaptation to COVID-19. The methodology that was used included a very extensive online mapping questionnaire with responses from 31 countries, 87 key informant interviews across the 7 case study countries, which included Afghanistan, Colombia, Cox's Bazar, Bangladesh, OPT, Sudan, and Syria and Yemen. The key findings of the study were then presented at 7 validation workshops at country level, which included 87 participants from those case study countries. And we also conducted an extensive secondary data review with documents at global and country level. Over 1,000 documents were reviewed in the process. Next slide, Heiko. Thank you. One of the areas that we mapped in the study was the type of strategic planning that was developed in response to COVID-19. So you can see here from the two graphics that national plans, SPRPs, were developed and existed from 2020 onwards. And COVID-19 response for populations affected by crisis were integrated into the GHRP in 2020 and HRPs in some countries, and incorporated to a greater extent in HRPs in 2021. When we asked respondents to the online mapping exercise, a significant majority of the respondents, so 77% in 2020 and 72% in 2021-22, felt that the plans were only partially successful in ensuring that populations affected by humanitarian crisis received COVID-19 services, most notably at subnational level. I'll hand over to Kim now to go through the findings in more detail for government and humanitarian coordination.
Thank you, Helen. So the study chose to disaggregate how it looked at findings between the humanitarian coordination mechanism as well as the government coordination mechanism, because during the COVID-19 in the country, we found that you have these two parallel coordination mechanisms, which sometimes can be enabler or sometimes can be a constraint. What the study found from the government coordination side is that most countries established national level coordination mechanisms, and this was activated at the highest level of decision making within government. So you will find a task force at the prime minister level or interministerial level to ensure that the right level of decision making was provided. The findings also show that partners were not often involved in supporting coordination function at the national level. Some were, but there was only a few cases. And while the partner coordination platform was established or adapted in 89% of the surveyed countries, only 11% of health cluster partners felt that the coordination was very beneficial, and similarly 11% also felt it was very appropriate. So the result of how partners felt about the government coordination mechanism was not very high. You can have more details on the two graphs that are shown here on the left. In terms of the capacity of the government to conduct coordination, what the study found was that at the beginning of the pandemic, most countries established presidential or interministerial task force, or specifically within MOH. At some national level, governor, district commissioner-led type task force were dominant with 89% of the country reporting, and followed by some national Ministry of Health task force, 57%. And this data came from the online mapping exercise. The study found that there was significant challenges in the capacity of the Ministry of Health to conduct coordination. And this included limited coordination experience for the people assigned to that task, limited transparency, accountability. Also, there was a identified lack of technical capacity for specific response pillar, as well as insufficient resources for IT and infrastructure, as well as a lack of skill information and data management. Moreover, it was also found that in many cases, there was a lack of clear role and responsibilities between national and subnational level. So the main point to take away here is that it's really important to reinforce national and subnational governance, coordination structure, and coordination capacity. From the humanitarian side, the first aspect we looked at was the access to the partner. And the study found that several countries reported that access had been restricted, delayed by government, despite having sometimes specific exemptions for health services. For example, the interference from government that included bureaucratic impediment and administrative impediment, which reduced the ability to maintain the Humanitarian principle. And that was particularly the case when government required to approve a specific project or insist in being involved in beneficiary selection or even sometimes in staff recruitment. In insecure context, the study also found that agencies struggle to reach and operate in area of high risk and insecurity. Also, the imposition of curfews significantly impacted the delivery of services. Moreover, access of humanitarian personnel was also impeded due to visa restriction, and as well as sometimes the institution of international staff presence. The study noted a few reports of discrimination where authorities limited access to health services due to social factors like caste or migration status. And the main takeaway was is that when there is a government will, access can be negotiated and discussion can be facilitated through existing coordination mechanisms. So when partners face access constraints, it's not something new, but negotiation and discussion always help, and the coordination platform also there to support that exercise. Next. For the humanitarian coordination mechanism per se, so looking at the way the health cluster adapted their way of working and increased or adapted the capacity to meet the demand. What the study found is that the humanitarian coordination mechanism established several COVID-19 working groups. So we found that the health cluster at national level, there was 58% of country reporting having a working group specific to COVID-19 and 47% at the national level. You can already see here there's a little discrepancy between national and some national level in terms of work. Health cluster working group also decreased in 2022 to 38%. So with time and with less attention or demand, the working group presence was reduced. So what we also see is that the decreasing focus, especially after such a time, had a possible negative impact on vaccination and continuation of essential services. I mean, we see that the peak of effort was really 2020, and then we can see a slow reduction of focus. Only 32% of HCT, humanitarian country team, and 21% of intercluster coordination group and intersector working group had a COVID-19 working group. However, what we also found is that it's good to adapt, but this also created a context where we found multiple overlapping coordination structure or multiple layers of coordination at different levels. And this was sometimes seen as a hindrance to effective coordination. Additionally, what the study found is that various sectors did not immediately realize that the pandemic was not just a health issue, and it took them time to engage and to look at the COVID-19 in a more broader scope and looking at it from a multi-sectoral point of view. And the lack of initial recognition created also difficulties to properly respond to COVID-19, especially not recognizing the scale of this need for multi-sectoral response. Next. Continuing in terms of the adaptation that the study found, there was quite some gap in coordination capacity, mostly related to information management. Because as you all know, during COVID-19, the demand for timely and more granular information product was very high, which created a lot of pressure for information management staff. and the timing as well, or the frequency of information project was very, very high. In addition, in some cases, to cope with the lack of capacity, some countries asked staff to double hats to perform several functions at the same time, including the coordination. And this also was seen as there was insufficient capacity in the subnational coordination structure. Coordination was often perceived as top-down from the national level. So we found there was capacity gap at some national level with lack of presence and or inconsistent engagement of national health cluster as well as senior WHO staff. When we look at how partners engage with coordination, it appeared that there was 79 countries reported that there was substantial change in how partners engage in coordination. And this change was seen as very beneficial at national level by 47% of respondents, while only 5% did not see it as appropriate or beneficial. So during the COVID-19, many countries have witnessed that the partners have been more proactive and engaged more strongly in order to contribute to the response to COVID-19. And one of the big changes that was identified was again about information management, and which was reported by 57% of the respondents, which was seen very beneficial at the national level by 44%. So not everybody sees that as beneficial, but still a strong portion of respondents that was very useful. Information sharing and information management channel for the health cluster was seen as an enabling factor by the partner. So one of the functions of the cluster in order to provide information or to receive information and reprocess information upward and downward was seen as something that allows partners to engage in coordination and the response to COVID-19. Next. Now, looking at the conditions for the international partner versus national partner, as you may know, or you probably know, there's always a bit of a distinct perception between international organization and national organization for good and bad reasons. So what the study found is that national health partners, local community-based organizations, as well as non-health partners, played a vital role in reaching hard-to-reach community, which obviously is the last mile for the delivery of services such as risk communication or AAP. But they are not always recognized or facilitated to play this role. The study found that the ability to mobilize funding was easier for international partners than for local partners, which I believe would not come as a surprise. And in terms of some of the issues related to funding, the study found that sometimes there was a lack of existing funding or challenges to reprogram existing funding to allow partners to readjust their programming and contribute to the coordination and the response to the COVID-19. And this limiting factor affected most local partners because they depended largely on the international partner to get funding. And one of the findings that came from the interagency humanitarian evaluation on the interagency work on COVID-19 humanitarian response, the study found that donors made unearmarked funding commitment and offered flexibility to reprogram existing funds, and that this flexibility was reduced over time, and that the earmarking then was returned at a later stage. The initial focus on supporting, empowering, and funding local and national partners has not really gained sustained commitment. So here, the nationalization agenda didn't seem to be very strongly supported. Next.
Thank you, Kim. This is the end of the first session. I would like now to ask Laura Osorio from our Colombia office, the Health Cluster Coordinator in Colombia, to present her case study. She will speak in Spanish, so I'm advising everyone to go down to the interpretation tab and click on English, or yes, on English. Laura, can you join? Can you put up your screen? You're on mute.
Hola, Heiko, buenos días para todos y todas. ¿Cómo están?
Muy bien.
Vamos a compartir, en este momento voy a compartir pantalla. ¿Me permiten un momento, por favor? ¿Ahí ven mi pantalla? Bueno, perfecto.
Sí.
Bueno, aquí en Colombia abordamos 10 pilares para el trabajo de la COVID-19. Esto lo digo antes de iniciar, planteando un poco los temas de comunicación del riesgo, el tema de vigilancia de base comunitaria, el tema de apoyo en insumos, el tema de manejo de casos. Dimos todo un acompañamiento técnico como OPS Colombia en el marco de 10 pilares. Sin embargo, en el marco de esta presentación, vamos a hacer énfasis en el apoyo territorial, más en el énfasis del enfoque territorial que tuvimos como grupo de salud en Colombia. En este escenario, solamente para poder plantearlo, tenemos en el mapa de azul, tenemos la afectación que tenemos este año en temas de víctimas del conflicto armado en Colombia, teniendo en cuenta la transformación y la reconfiguración del conflicto en el país. Más de 32.500 personas han sido afectadas y esto tiene un significado y un sentido en materia de los mapas, porque ahorita vamos a ver cómo estuvo la vulnerabilidad de COVID-19 y cómo esto, si lo sobreponemos, encontramos que son muchos grupos poblacionales muy relacionados con doble o triple afectación. En el mapa verde encontramos que este año hemos tenido más de 78.000 personas afectadas por eventos de variabilidad climática y donde se combinan las afectaciones. Es importante resaltar acá que la COVID-19 impactó de manera directa las desigualdades en salud de la población, que logró acentuar las vulnerabilidades para la población que históricamente ha venido siendo afectada por otras crisis, que tuvimos, por ejemplo, en dinámicas de conflicto armado y en relación con las dinámicas migratorias, tuvimos amenazas y asesinatos hacia personas que tenían un diagnóstico de COVID y que los grupos armados señalaban como objetivo. Lo siguiente es que en el marco del acceso humanitario y ante la reconfiguración del conflicto, pues tuvimos una desaceleración del desarrollo, pero también mayores barreras para el acceso humanitario y normas impuestas de manera directa por grupos armados en Colombia, lo cual nos pone en un escenario diferente en materia de pandemia. Por supuesto. Sumado a lo anterior, tenemos la severidad en el país, que como resultó posterior a 2 años de pandemia, cómo estamos hoy como país reconociendo la necesidad en salud de los grupos poblacionales. En esta severidad vemos que el PIN de salud, en vez de disminuir, se incrementó. Y esta es otra de las lecciones de la pandemia, porque si bien no teníamos los elementos necesarios para la respuesta en territorios rurales, pues también encontramos que se deterioró el acceso a salud y las pocas infraestructuras rurales pues han tenido una afectación a causa de las otras emergencias. Queremos resaltar los siguientes puntos que van muy en relación no solamente posterior a la COVID-19, sino lo que está pasando en este momento con Colombia. El incremento de las camas o el incremento de la capacidad se dio de manera concentrada en territorios urbanos. Y esto pues también sigue incrementando, que si bien se aumentó la capacidad en zonas urbanas, en zonas rurales siguieron con las mismas capacidades y con un impacto mayor sobre las emergencias. Aproximadamente 8.5 millones de personas continúan experimentando barreras para el acceso. 1.3 millones de personas con discapacidad siguen experimentando barreras. Y en consecuencia, por el modelo de sistema de salud que tenemos en Colombia, la población que no asegurada asciende un porcentaje mayor en zonas rurales e indígenas y en población migrante y refugiada. Este es un poco el panorama de la COVID-19. Aquí vemos las áreas vulnerables a la COVID-19, en donde en las fuentes 8, en donde se selecciona, por ejemplo, zonas de frontera. Nuestro país, por la diversidad, tenemos una gran cantidad de población indígena, entonces lo que ven en verde más oscuro son los de mayor afectación, como el Amazonas, Nariño, Putumayo, Guajira, Arauca. Y aquí son las áreas vulnerables frente a dinámicas de migración, que también continúan siendo las fronteras. Y en donde la población migrante posiblemente fue esa población los que se encontraban en situación irregular, los que tuvieron un menor acceso a servicios de salud en el marco de la pandemia. Porque si bien, como les decía, el sistema de salud colombiano facilita el acceso por urgencias a cualquier población, no importa su nacionalidad o su estatus migratorio, pues ya un traslado o en los procesos de referencia y contrarreferencia, las barreras se incrementaron para estos grupos poblacionales. En general, así estamos conformados en Colombia. Tenemos 80 socios en este momento, en donde hacen parte no solamente el Estado, nosotros colideramos el clúster con el Ministerio de Salud, pero aquí también están las agencias de Naciones Unidas, las organizaciones nacionales, internacionales, donantes, observadores, sociedad civil y academia. Este escenario de articulación, si bien lo tenemos a nivel nacional pues, y en el marco de la pandemia, vimos la necesidad de poder hacer espacios territoriales que facilitaran, teniendo en cuenta las características de los contextos, espacios territoriales de coordinación en donde se diera una mayor participación a la sociedad civil y a la comunidad. En general, tuvimos una hoja de ruta de acompañamiento territorial en donde tuvimos un diagnóstico del panorama general, una priorización de territorios, una participación comunitaria, un diseño de una hoja de ruta que articulara las entidades territoriales o las entidades locales, la comunidad, las organizaciones de cooperación y otras instituciones. ¿Cómo lograron identificar las necesidades teniendo en cuenta el plan nacional que se tenía de respuesta a la COVID y cómo nos permitió tener aprendizajes continuos en el marco de la respuesta? ¿Cómo se levantó y se consolidó la información teniendo en cuenta necesidades, obstáculos y oportunidades evidenciadas en cada territorio? cómo se tuvieron visitas territoriales para poder activar la respuesta, cómo se validó y se logró esa articulación entre lo local y lo nacional, y finalmente cómo se lograban llevar a cabo esas respuestas territoriales y contextualizadas en el marco de la pandemia. Esto digamos que fue el escenario. ¿Qué retos encontramos ya para finalizar? Los socios, cuando no encuentran respuesta del Ministerio Nacional, van directamente al territorio. Es decir, si el ministerio no se mueve rápidamente en dar información y en dar lineamiento, los socios llegan a territorio porque muchos de los donantes ya habían entregado recursos. Segundo, pueden haber duplicidad de acciones, porque en la medida en que no se tenga un lineamiento nacional, los territorios tampoco determinan un lineamiento territorial. Y adicional, pues se pueden ir, cualquiera puede decir y estimar lo que se necesitó para un territorio y proyectarlo para todo el país, pero posiblemente esa no sea la necesidad. Lo tercero es que en el marco de la pandemia, pues se desatendieron otras necesidades, muchas cosas pasaron a ser virtual y si bien facilitaron procesos de temas de respuesta en salud, en otros, pues debilitaron esa respuesta humanitaria. Y en otros, pues digamos que se dejaron desatendidos algunos grupos poblacionales porque se concentraron los esfuerzos en la respuesta a la COVID-19. Eso digamos que de manera general, con las comunidades indígenas, dentro de uno de los pilares que mencioné inicialmente, pues se tuvo un fuerte componente de comunicación y cómo lográbamos de manera contextual adaptar la información de la COVID-19 al lenguaje o al idioma o a todas las características sociales y culturales desde la participación comunitaria. En vigilancia, la vigilancia cumplió un papel fundamental en la respuesta, el acompañamiento técnico de la respuesta técnica digamos que a todo este escenario, facilitó una orientación clara frente a los nuevos lineamientos. Eso era un poco lo que les queríamos compartir. Quedamos muy abiertos para preguntas. Muchas gracias.
Great, thank you. I think if we all head back to the original audio stream, Laura, thank you very much for your presentation. We actually intended now to open the floor to the audience for questions, but we have fallen a little bit behind time. So I will share my screen and ask Kim and Helen to continue with the summing up of the findings, and then we will have another chance to discuss.
Okay, so we move straight to
sorry.
yeah. SPRP first.
Yes.
Yeah. Okay. Okay. So I'll go quickly because I know we're a little bit behind on time, but just a few more detailed findings on the SPRP or pillar approach. So this was seen, the SPRP pillar approach was seen as a key enabler to help define areas of operations and technical focus, created a structure for partners to engage in coordination, planning, operationalization. So for example, the vaccination was recognized as a standalone component that required a dedicated pillar to support articulation and coordination of the strategic approach. It was seen to improve coordination between MOH and health cluster partners, facilitating the development of joint strategies, particularly in accessing affected populations and delivery of services in hard to reach areas. However, what we found from the case studies is that partners were often not involved in supporting coordination functions for SPRP pillars at the national level. There was, however, more involvement in leading and co-leading at the subnational level. So respondents in the case studies stressed that in a lot of the context, the establishment of strategy and decision-making was very centralized in government coordination, and partners were mostly given strategies and plans that had already been validated rather than being involved in their development. In the study, we also mapped the use of PHEOC in coordination of COVID-19 response, and our findings show that PHEOC's public health emergency operating centres were used quite extensively in response to COVID-19 at national level, just over 50%, and at subnational level, extensively at 60% were used to support coordination of COVID-19 response. This decreased from 2021 onwards to 44% at national level and 50% at subnational level. And this compares to prior to the COVID-19 pandemic. At subnational level, 73% of countries were reported using PHEOC to coordinate other public health emergencies. And for non-COVID-19 emergency response, the use of PHEOC dropped in 2020, but then increased again during the COVID-19 pandemic, and then increased again in 2021 as the pandemic was slowing down. In 2021, we also found from the study the use of the One Health platform. That was also reported in some countries. So some key takeaways that this shows is that the PHEOC were found to enable coordination with partners and enable information sharing. And so what we can conclude from this is that existing structures should be strengthened or new ones established. Maintaining the PHEOCs, however, is incredibly labor intensive and resource intensive, and so needs to be supported at appropriate levels. And PHEOC coordination needs to incorporate national and subnational levels. I'll hand back to Heiko.
Thank you very much. We are going to have a very short intermission now. I would like to ask them to open the floor to ask partners to tell us, we will have 5 minutes for this only. How did coordination work for you in your experience during the last 3 years? How did it work? And for instance, did the emergency operating centers benefit you? Did the SPRP approach, the pillar approach, the structure, did it work? Did it benefit coordination? So I'm going to open the floor. Please raise your hand or put your question in the chat. We have 5 minutes. Nobody? We can as well go on. We have a few more slides on challenges and successes and come back to the discussion at a later stage.
Okay, so now I'm going to sum up the challenges, successes and good practices and key takeaways before we move to a discussion and then following with the recommendations of the study. So in terms of some of the key challenges, coordination, as we've mentioned, with some governments proved challenging at times due to limited coordination capacity and information sharing capacity. Lack of reliable and accurate data from government was observed in most of the case study countries, if not all. The focus on COVID-19 diverted a lot of attention away from other essential health services and overloaded some humanitarian partners. There were significant supply issues across most of the case study countries that were reported, including delivery of PPE equipment and essential supplies. To highlight some of the successes and good practices, national COVID-19 task forces, working groups and sub-working groups that were established under the health clusters were considered essential to coordination of the response. Health clusters were considered critical in developing and contextualizing and disseminating guidelines, protocols and SOPs to support the delivery of COVID-19 services. The SPRP approach was seen as most effective when subnational coordination was integrative. So with partners being engaged in planning, coordination, operationalization, which was observed much more, which was reported much more at a subnational level, whereas at national level, there was much less involvement in development of strategy and strategic planning. Pre-existing health service delivery helped ensure access to health services for camp populations, especially when there were movement restrictions. So pre-existing integrated programs demonstrated that specialized services could be more readily maintained in contexts, even when there were movement restrictions, but health activities were prioritized by governments. Next slide, please. Okay, so moving on to key takeaways. Continuous efforts by partners, health clusters and HCT on humanitarian advocacy help to ensure access to essential services by populations affected by crisis. It's essential to link national coordination with humanitarian coordination from subnational to national level to ensure coherence in the coordination structures. The highest level of government ownership and coordination with HCT or ICCG, ISWG to ensure coherence and partner engagement is essential. Government and MOH coordination capacity needs to be invested in significantly and strengthened at national and subnational level during emergencies. Ensuring alignment of response is particularly important. Health cluster coordination linked to humanitarian strategic plans and to government strategic plans, again, to ensure coherence. PHOCs improve coordination, technical cohesion, information management and partner engagement capacity, and continuing to invest in them is important to improve coordination. And information management is key to achieving impactful coordination. IM support from WHO and other humanitarian partners needs to be prioritized for future emergencies. Thank you. Over to you, Heiko.
Thank you, Helen. Before we then go on looking at the recommendations, we would like to hear from you. We had asked you initially to head over to the Mentimeter to put in some thoughts on how coordination for you went. Fasika, can I ask you to put up the slide of what colleagues have entered? Challenging as the main one. Challenging followed by helpful, or helpful followed by challenging. Good. Slow start, yes. This is what the colleagues also found in the study. Oh, People are still putting in. Good. Challenging. Not enough. Yes, probably there's never enough coordination, but there can also be too much. So I think finding the right balance, especially when you have different sectors to contribute and to navigate. Confused. It can be confusing. Limited resources. Yes, I would have actually expected that to be bigger in size, to have been flagged a bit more.
Actually, Heiko, I think these words are quite interesting because what we found in the study is that some aspects were reported to be very helpful, but some aspects of the coordination were also reported to be very challenging. Complexity is something that came out quite strongly. The fact that there were multiple coordination structure and platform also created a lot of confusion. So I think it's interesting that all this feedback from the partner is quite accurate actually from what we found in the study itself. If you look at just this wording.
And we should not forget, not two countries are the same. Every country is different. Every country has its challenges. Coordination needs to be contextualized. This is also something that we have learned. Thank you very much. We, in the interest of time, I would say we can again give it 5 minutes for partners to come in if they wish. Otherwise, we continue with the recommendations and then open the floor for the Q&A session at the end. I'll just give it a minute to see if somebody's popping up their hand. Kevin from CDC, please go ahead.
Thank you, Heiko, and thank you to the presenters for a very insightful webinar. My question, it might be a bit more for Helen, but invite anyone who would like to field it. Acknowledging that this study and the perspective is largely through the health cluster and the government coordination perspective, I'm curious if any of the informants were from other clusters and how the key takeaways, what the perspective of the key takeaways that you highlighted might be or might vary by individuals from other clusters, noting your points earlier on how perhaps early in the pandemic the sectors didn't all view it as their issue and what our collective priorities have to be for pandemic preparedness and response with an intersectoral approach. So yeah, just to refresh, just to clarify and restate it, I think if there's any disaggregation in your data by other sectors, clusters, would be interesting to know. Thank you.
I will take that on, Heiko. Thank you, Kevin. Just to say first that there is a study specific to the multi-sector collaboration for the health sector health cluster response in COVID-19. So you will have much more detail in that particular studies. However, for our study, we interviewed several people within the inter-cluster coordination. So we didn't talk directly to other clusters, but we talked to the inter-cluster coordination group or inter-sector coordination group, which from where we got this information that there was a late recognition of the multi-sector nature of pandemics such as COVID-19. And at the beginning, people were too focused on the health aspect and neglected the whole economic and other impact that the the COVID-19 created. We don't have too many granular data for that particular question, but I believe you will have much more detail on the multi-sector collaboration study. Over to you.
Thank you.
Thank you, Kevin. Thank you, Kim. And yes, we will actually be talking about the study and the aspects of multi-sectoral collaboration in 2 weeks at the Health Cluster Partners meeting. There'll be a session, and we will also be presenting the findings of that study. So I think we'll go on with the presentation of the recommendations. Over to you, Kim.
Thank you, Heiko. So here we are going to present the key recommendations that the study generated out of this research. And for that, we structure the recommendation by target audience. So the first recommendation are for the government, because basically we have several stakeholders here for everything related to preparedness. We have the government side, we have the global health cluster at the global level, you have the health cluster at the country level, you have the health cluster partner, and you have the donor. So these are the major stakeholders that we have identified that we wanted to push recommendation toward to. And for the government, what we would like the government to take into account is that they need to recognize the importance of coordination and invest in resources and effort. As mentioned before, in the study, we found that the role and responsibility were not always very clear, or the people assigned to ensure the coordination from the government side were not very familiar with what coordination entailed. And so this created quite a lot of challenges. We just spoke a little earlier about the multi-sectoral nature of a pandemic crisis. And so for government, they really need to ensure that when they create a task force, they need to be interministerial task force that include all the relevant sectors, and they need to have a strategy, as well as continuing to use a pillar approach, which was found by many as a very good way to structure the coordination and response to COVID-19. Also, we would like government to strengthen and leverage the partner engagement. We had a lot of information about partner engagement with humanitarian coordination mechanism, but when it came to government, it was much less. And we also found that within the government coordination mechanism, the recognition of partner was still not at the level that we could hope for. And so government needs to ensure that they have partner engaged at the right level to ensure appropriate and relevant planning and response. Also, we would like the government to strengthen linkages between subnational and national level, so that the strategic planning integrate appropriately all the subnational needs. And lastly, to government, which is not always easy for government, but it's very important for partners that there is a better transparency in how decisions are being made. Next. Coming to the recommendation to the Global Health Cluster, and one has to acknowledge that the Global Health Cluster has made tremendous effort to enhance, improve its support and its work for the coordination. And as such, we recommend to the Global Health Cluster to sustain its investment, particularly in information management resources. New pandemic will require potentially the same level of frequency of information projects. Also, for the Global Health Cluster, we recommend to continue investing in capacity building for the health cluster at national and subnational level, especially with skills for advocacy and negotiation. Continue to invest in training related to public health emergency, health cluster coordination system, having POCs and relevant guidelines. Also, to ensure that the coordination functions are ring-fenced at the country level, and need to ensure that there is dedicated funding for national and subnational level so that the personnel can be deployed. It needs also to strengthen multi-sectoral coordination and strategic approaches for outbreak responses by reinforcing the interface between health cluster and other cluster in the intercluster coordination group or intersector working group. And lastly, to continue prioritizing joint and multi-sectoral assessment. Next. To the health cluster at country level, and that also includes the support from WHO country office, is to reinforce partner engagement and information management during pandemic, to support capacity, to rapidly scale up and strengthen coordination structure. By that, we think about search capacity for coordination, data analysis, data visualization, information management. Also have access to rapid funding and invest in subnational coordination capacity for local partners to take on. In many places, because of the different constraints of context in which agency operates, sometimes local partners are best placed to support subnational coordination because of their presence, their acceptance, and knowledge of a specific area, while health cluster cannot be deployed at every level. Also, at country level, health cluster need to continue to advocate and highlight with all stakeholders the health threats and how it impacts all sectors. And let's come back to the point about the multi-sector nature of a pandemic. Also, they need to draw lessons learned from the COVID-19 response to retain essential functions if we have to face new pandemic in the future. Streamlining coordination platform is quite key, and ensuring data sharing among health partners needs to be continued. And one important aspect is that not to be diverted, that the focus should not be diverted from ensuring the continuation of essential services. The study found that in many cases, because the media attention, the public attention, the decision maker attention was all on focus on COVID-19, we found that there was a diversion of attention, which created gap in the maintenance of essential services. Lastly, the country should also invest in rapid response function, especially for health logistics, particularly at the outset of the pandemic. We know that for pandemic, we had, especially for COVID-19, we needed to import a lot of supplies, whether it is oxygen, PPE, or even vaccine. Next. To the partner. So partner are an essential component for the coordination, and therefore what we like partner to pay attention to is to ensure that they can dedicate time and the resources to coordination at both national and subnational levels. It's very important. That they also partner could consider to co-coordinate technical working group. We had some few examples where it happened, but it was not something generalized. And they could also be co-coordinating a pillar at national or subnational level in area where they have expertise, complementing the SPRP approach. Also, the partner needs to consider supporting the Ministry of Health where appropriate with basic coordination and planning function, particularly at subnational level where capacity were found to be often constrained. Partner needs to continue supporting health cluster by sharing information in a timely manner. It's very important. Information is one of the main food for coordination, whether it's to process it and send it upward or feed it back downward. But the partner are one of the primary source of information for the cluster, so that's very, very essential. Also, partner, when possible, should contribute technically with such capacity to help the integration of needs of population affected by crisis. The expertise and the contextual knowledge of partner are often very key in understanding the reality in which population are evolving. And lastly, we need a partner to continue advocate with WHO as a critical lead agency and as well with NGO representative in HCT to ensure population affected by crisis are duly considered and reached. So we don't see gap in the provision of essential health services, for example, and ensure that there is a meaningful space for NGO to be able to operate and to be involved in planning and implementation. Next. So to the donor, because they are the one who give us the meat so that we can do our work, what we would like them is that they continue to invest in capacitating MOH and or the health cluster with self-search staff when required so that they can have like a secondment. Invest in partner to support co-leadership or co-coordination of clinical working group or to support MOH. We ask partner to be more present in co-coordinating or providing co-leadership, but obviously this has a resource implication which needs to be supported by donor when possible. We would like the donor to have continue to have a greater focus on supporting local NGO, especially at the national level. They have a very key role and they also need resources to be able to support coordination because the study found that often national NGO are quite dependent on international NGO to get funding. And as mentioned, they are an essential partner for the service delivery. So we need them to be not just dependent, but they can have more funding so they can provide more support as well. When possible, we would like donors to support or to be involved in national planning processes so that we can advocate for planning for population affected by crisis. And when a crisis like COVID-19 happen, increase or repurpose funding. That's quite key because if that's done quickly, the partners can be rapidly operational. They are often very flexible and agile, but this always depends on whether or not they can have access to flexible funding so that they can adapt their programming. And the study found that the main obstacle to the agility was this lack of funding or this inability to redirect existing funding. Thank you, Aiko.
Sorry, I was still on mute. Thank you very much, Kim. Thanks, Kim and Helen, for the presentation of the findings. On the screen now, you have the link to the report, which will be copying into the chat. So no worries, you will find it on the website of the health cluster. So before we go into the discussion, I have a few more slides that I want to show you. We have been thinking about, and not only thinking, but also working on some of the next steps. So our roadmap here from the Global Health Cluster is to look at specific needs that you have, but also carve out the good practices that we can turn into lessons learned, into readiness for pandemic preparedness in the future. We have already worked on a compendium of tools that is supposed to be a user-friendly library of COVID SOPs, guidance, protocols, checklists, dashboards, and IEC materials that has been developed by Health Cluster and partners around the world in many countries between 2020 and 2022. This is on track for release in the summer, and we will present this to you in due course. We, as Eba has said in the beginning, also are looking at producing and developing some checklists, some documents and tools that incorporate those good practices and lessons learned. I mean, we always tend to focus a lot on the gaps and the challenges, but I think what we need or what we can draw from these studies is the wealth of good practices of successful overcoming challenges or partners and cluster coordinators taking the initiatives to engage with government counterparts. The advocacy, particularly also the advances around multi-sector collaboration, which we'll come to in our next webinar in 2 weeks, and also on risk communication and community engagement. So all of these things are extremely important. So apart from the tools that we're thinking of, we're also thinking of thematic webinars, and I've just outlined here a few of those concepts that we are looking to develop further. We have on one side the documentation and the sharing of the best practices, good practices around coordination capacity, everything that we've heard today, the community engagement, intersectoral initiatives. We also want on the other side to look at some of the emerging evidence that is being built into new strategic frameworks like the Health Emergency Preparedness Response and Readiness framework. We also think that there's always a need to look at emergency operating centers, incidents management systems, so to familiarize ourselves again and again and again with pandemic preparedness, because the next one is going to come and we need to be ready. And this is where we want to engage with you in the next months to develop these tools, to start these series of webinars and workshops, to get going on this as a learning. And here I stop and open the floor. I'm sorry, we're a little bit behind time. I see some in the chat. So hold on. I will look at what we already have in the chat. Okay, so this is just the links to the documents. So with this, I open the floor to the audience. Please raise your hand, and we have about 10-15 minutes. We can do a good 15 minutes for discussion.
Heiko, Breda from Concern, she put something in the chat. I don't know if she wants to come off mic. Breda, you're online still, so if you want to discuss.
All right, up here, yes.
That'd be great. And also Dr. Nasser, who's the co-coordinator from Whole of Syria. I'm not sure if he is still online. Perhaps Breda, if you go first.
Okay, thanks everyone. Thanks for the interesting update. Yeah, in my experience, especially working with teams in Sierra Leone, Liberia, and Malawi, and learning from this going forward, I think it's really important that, as well as NGOs in the clusters, that donors actually coordinate more to support strengthening of Ministry of Health teams to lead the responses. And I have concerns going forward about the distrust in vaccines. We see lower uptake currently still in terms of measles and other essential, especially the 6 diseases. I'm wondering what we can do about that to get ministries of health back to promoting the essential life-saving vaccinations there for especially children under 5 and mothers of reproductive age, like tetanus toxoid. Thank you.
I think with this particular concern, you will get EBA into overdrive. We will have sessions on vaccination during the partners meeting in 2 weeks. But EBA, maybe you want to respond quickly.
There's no quick answer. It's she's right. What can we say? But there is a lot of concerted effort around this through, well, what was COVID-DP, but then now as everyone's going back to their usual COVID-19 sort of structures within Gavi and WHO and UNICEF, there's a clear recognition that vaccine hesitancy or vaccine acceptance, even for routine EPI, has been really knocked. So yeah, we can have more of a discussion on this in the cluster partner meeting around vaccination. But it's not unwarranted, your concern, but it's not being neglected, I don't think. I think it's high on everyone in the vaccine world. It's on their agenda. But I hear what you're saying also about the coordination around the donors and strengthening ministries of health around that as well. But we'll explore that more in the vaccination study. But agree with you, Rita. Thank you.
Thank you.
Nasser, do you want to go first? Second? I don't think he's. I think he dropped out.
Yeah, I think he's not online anymore. It's a shame. But his interest, he's the whole of Syria co-coordinator. And his comment was very interesting, which was that actually also the COVID-19 pandemic also served as an access point for strengthening coordination, both between governments and given the complex situation in Syria, but also for intersectoral. Of course, there's still multiple challenges in Syria, but advanced, it helped as well. I see Kevin's got his hand up again. Over.
Thanks, Eva. Yeah, on the information management recommendations, I would encourage expanding beyond just investing in information management surge resources if the data supports that. I think from my personal anecdotal experience, there were global IM partner surge capacities that were available but not utilized in some settings due to either a lack of identifying or prioritizing the need at country level or the lack of permissive policies at the national level, allowing more partners to support the information management work due to data sharing concerns. So just to highlight that, I think there are a couple strategic facets of that moving forward beyond just the resources that may be worth emphasizing as well. Okay.
I think that's a really, really important point, actually, Kevin. Yeah, maybe this is something we can deep dive a bit more, because information management keeps on coming up all the time. So perhaps in the next few months as we go forward, we just unpack that a bit more and just think what those bottlenecks are, both for, not just for the health cluster, I mean, it's for anyone, but definitely within ministries of health. That would be super pertinent, I think. Yeah, thanks for that.
Just on that point, Eva, in terms of information management, we need to be a little careful, because on the study, we didn't dive very deep in terms of the specificity of every aspect of information management. But as you know, nowadays, information management is a bit of a junk word, because actually we use more like data scientists, data engineer, data pipeline, data visualization, GIS. These are all new type of skill sets that are required now in order to be able to produce the relevant information management product. So this is something that needs to pay attention when you look at that aspect in the future. Over.
Yeah, well copied. I think we see across all the studies, though, that information management is a critical bottleneck. And even if you just look at WHO Health, the emergency preparedness response drafts coming up, that it's very clear that information management and coordination needs to be supported. It's an enabler, but then the questions are, what are those bottlenecks? Yes, this study didn't look at it, but this could be something we deep dive into as we go forward over the next few months.
Yes. Anybody else? We still have a few minutes. Good. I think we gave you a lot of information. There was a wealth of information in this study, and the findings and recommendations need to be digested. It's a lot. We'll make this presentation and also the recording of this session available to you. You have access to the report that you can read in detail. There's a lot that we've learned from this session, from the study, from this webinar today. And going forward, we have the roadmap that I presented of some of the activities that we would like to continue taking forward with you jointly. So in terms of next steps for us, I think we will meet with many of you and with others who are not able to join today in Geneva in 2 weeks, where we will also look at some of the aspects of the other studies. And this will then complete the picture more holistically, where we then develop some tools and learnings around some of the themes that have already come out today: coordination capacity, integration of humanitarian government and strategic coordination aspects, information management, also the support to local and national NGOs who are really the workforce on the ground to enable us to actually reach the last mile. Very important aspect also in the whole discussion on the vaccination, because as we will see when we talk about it in 2 weeks, there is often a disconnect, and the study has shown this as well, between national level coordination and subnational local level. So there's a lot of gaps and opportunities, and there's a lot of a wealth of good practices that we want to carve out. And I hope that you all are with us in this next month to actually establish this as a good practice basis for lessons learned, for getting prepared for the next time, getting better for our work in humanitarian settings. With this, I would like to thank everybody. Eva, do you want to say any last words? If not, then I will.
I'm just going to say thank you. Thank you.
So,
Thank you for everyone's absolute dedication. It's been incredible. And just in general, how we all work together. Yeah, I think we're at a space now in time where we recognize that we really need to be working together to work out those gaps and just make those synergies happen. So it's all down to everyone putting their bit in and putting their feet together. Over.
thank you. So yes, I would like to thank the colleagues from the Operations Partnership, Kim and Helen, for first conducting the study and then presenting it today. I would like to thank Laura from Colombia and also the audience for your inputs. I would like to thank again the READY initiative for providing us with the IT support and the interpretation services. A big thanks to the interpreters. And with this, I think we can close. Thank you very much, everybody, and hope to see you in 2 weeks.
Thank you. Thank you very much. Bye-bye.
Thanks, everyone.